Hypertensive Emergencies, Diagnosis and Treatment. Jamie Johnston, M.D. University of Pittsburgh School of Medicine. Today's Roadmap Case Presentations Definitions Evaluation Management will not cover preeclampsia or pediatric hypertensive emergencies. Case 1 51-year-old man admitted to an outside hospital. CC, sudden onset of left-sided weakness, severe headache, slurred speech and left facial droop. BP 260-172. Head CT scan showed right basal ganglia hemorrhage with shift. HPI, transported by air ambulance to PU. Intubated en route due to declining mental status. Case 1. PMH, hypertension, according to wife, patient was non-adherent with prescribed medications. Outpatient medications and allergies, not available. Family history plus for HTN/CVA. Example, BP 196-130. Positive for left dense hemiparesis. Case 1 hospital day 2 subsequent hospital course dilated right pupil. Emergent right frontotemporal craniotomy and evacuation of clot. Subsequent hospital course. Difficult to control BP. Pneumonia, Case 1. Renal MRI. Right kidney 8.1 cm with 3 renal arteries. Left kidney 12.2 cm with 2 renal arteries. Patient transferred to rehab at Southside Hospital on July 19, 2007. Question 1. What is the primary reason for hypertensive emergencies in the USA today? Renovascular disease. Pheochromocytoma. Non-adherence to antihypertensive medication. Hyperaldosteronism. Erythropoietin. What is the primary reason for hypertensive emergencies in the USA today? Renovascular disease. Pheochromocytoma. Non-adherence to antihypertensive medication. Hyperaldosteronism. Erythropoietin. 10. When you hear hoofbeats. Hypertensive emergency. According to the Joint National Committee on Hypertension report, severely elevated blood pressure with signs and symptoms of acute end organ damage. Requires hospitalization. Requires parenteral medication, hypertensive urgency. Severely elevated blood pressure without signs and symptoms of acute end organ damage. Can be managed as an outpatient. Can be managed with oral medications. Hypertensive emergency. CNS, encephalopathy, intracranial hemorrhage, grade 3 to 4 retinopathy. Damage. Heart, CHF, ME, angina. Kidneys, acute kidney injury, microscopic hematuria. Vasculature, aortic dissection, eclampsia. Vasculature. Epidemiology. Hypertensive emergencies are common. Occur in 1 to 2% of the hypertensive population. But, 50 million hypertensive Americans. 500,000 hypertensive emergencies/year. Parallels the distribution of primary hypertension. Higher in the elderly and African Americans. Incidence in men 2 times higher than in women. Epidemiology. Common associations. Previous history of hypertension. Lack of a primary care physician. Non-adherence to antihypertensive regimen. Illicit drug use, cocaine. Pathophysiology. Sudden increase in systemic vascular resistance. Mechanical stress with endothelial injury, increased permeability, coag/PLT activation, fibrin deposition. BP. Fibrinoid necrosis. Ischemia. Activation of Ra. Pro-inflammatory cytokines. Vaughan and Delandy Lancet 2000, 356-411. Underlying etiology? Unclear, but some candidates say STD genotype. Absence of the B and G subunit of INAC. Elevated adrenomedulin levels. Elevated natriuretic peptide level. Abnormalities in oxidative stress markers and endothelial dysfunction. Correct after effective BP treatment. Underlying etiology? Question 2. What is the most common complaint in hypertensive emergency? Neurologic defect. Gross hematuria. Chest pain. Headache. Epistaxis. What is the most common complaint in hypertensive emergency? Neurologic defect. Gross hematuria. Chest pain. Headache. Epistaxis. Clinical presentation? Variable. Zampaglione et al., Hypertension 27-144, 1996. 14, 209 ER visits in 1-year period. 108 Met definition of hypertensive emergency, 0.8%. Mean systolic BP 210 plus 32. Mean diastolic BP 130 plus 15. Clinical presentation? Frequency of signs and symptoms. Chest pain 27%. Dyspnea 22%. Neurodefect 21%. Interestingly, headache was only 3% and epistaxis was 0% in this study. Question 3. Hypertensive emergency is associated with a threshold BP of systolic greater than 225 mm Hg, diastolic greater than 110 mm Hg, systolic greater than 250 mm Hg, diastolic greater than 120 mm Hg. All of the above. Hypertensive emergency is associated with a threshold BP of systolic greater than 225 mm Hg, diastolic greater than 110 mm Hg, systolic greater than 250 mm Hg, diastolic greater than 120 mm Hg. All of the above. Threshold BP. There is no specific BP where hypertensive emergencies occur. But, organ dysfunction is rare with diastolic BPs less than 130 mm Hg. Rate of increase may be more important. Hence, encephalopathy will occur at lower BPs in pregnancy and in children. Initial evaluation focused history of hypertension. How well is hypertension controlled? What antihypertensives? Adherence to antihypertensive regimen? Last dose of antihypertensive? Initial evaluation social history recreational drugs amphetamines? Cocaine? Phencyclidine. Initial evaluation confirm BP in both arms. Use appropriate sized BP cuff. Cuff that is too small. BP cuffs that are too small falsely elevate BP measurements in obese patients. Initial evaluation assess for end organ damage vascular disease. Assess pulses in all extremities. Auscultate over renal arteries for Bruits. Cardiopulmonary. Listen for rales, CHF. Murmurs or gallops. Initial evaluation neurologic exam retinal exam. Hypertensive encephalopathy, mental status changes, nausea, vomiting, seizures. Lateralizing signs uncommon and suggest cerebrovascular accident. Retinal exam. Lost heart. Keith-Wagner-Barker classification, Keith-Wagner-Barker classification. Grade 1. Mild narrowing of the arterioles. Copper wire. Grade 2. Moderate narrowing, copper wire and avenue nicking. Changes associated with long-standing essential hypertension. Normal. Grade 1. Keith-Wagner-Barker classification. Grade 3. Severe narrowing, silver wire changes, hemorrhage, cotton wool spots, heart exudates. Grade 4. Grade 3 plus papilledema. Grade 3 and 4 highly correlated with progression to end organ damage and decreased survival. Grade 3 KWB retinopathy. Lab testing ECG renal function tests, urine included, CBC. LVH, look for signs of ischemia, injury, infarct. Renal function tests, urine included. Elevated BUN, creatinine, proteinuria, hematuria. CBC. CXR, pulmonary edema, aortic arch, cardiac enlargement. Lab testing aortic dissection? Pulmonary edema/CHF. Suspect with severe tearing chest pain, unequal pulses, widened mediastinum. Contrast chest CT scan or MRI. Pulmonary edema/CHF. Transthoracic echocardiogram. Differentiate between systolic dysfunction, diastolic dysfunction, mitral regurgitation. Management elevated BP without target organ damage. Hypertensive urgency. Oral meds. Goal, gradual reduction of BP over 24 to 48 hours. Management elevated BP with target organ damage hypertensive emergency. Parenteral meds. Goal, reduce diastolic BP by 10 to 15% or to 110 mm Hg over a period of 30 to 60 minutes. How quickly? Cerebral blood flow autoregulation. Cerebral blood constant in normotensive individuals over range of MAPS of 60–120 mm Hg. In chronically hypertensive patients autoregulatory range is higher. MAP range 100 to 120 to 150 to 160 mm Hg. Autoregulation also impaired in the elderly and those with cerebrovascular disease. How quickly? General rule is to lower MAP by 20% in first hour. Should always be done with close clinical observation. Management where? Which parenteral meds? Depends on the situation. ICU with close monitoring. Severe requires intra-arterial BP monitoring. Which parenteral meds? Depends on the situation. Question 4. Which of the following drugs should not be used to treat hypertensive emergency? Sublingual nifedipine. Labetalol. ACE inhibitors. Nicardipine. 1 and 3. Which of the following drugs should not be used to treat hypertensive emergency? Sublingual nifedipine. Labetalol. ACE inhibitors. Nicardipine. 1 and 3. Preferred agents: beta blockers, calcium entry blocker. Labetalol. Esmolol. Calcium entry blocker. Nicardipine. Dopamine 1 receptor agonist. Phenyldipam. Vasodilators, nitroprusside/nitroglycerin. Scenarios are case, acute ischemic stroke/cerebrovascular bleed. Agents: phenyldopam. Labetalol. Nicardipine. CVA or ischemic stroke. BP elevation after CVA or ischemic stroke can be protective to preserve cerebral perfusion. Hold on aggressive lowering unless thrombolytic therapy anticipated or BP excessively high, SBP greater than 220 mm Hg or DBP greater than 120. BP goal for thrombolytic therapy is to lower SBP if greater than 185 or DBP greater than 110. Cardiac conditions: acute pulmonary edema with systolic dysfunction. Nicardipine, phenol-dopam, sodium nitroprusside, nitroglycerin, loop diuretic. Cardiac conditions: acute pulmonary edema with diastolic dysfunction. Esmolol, metoprolol, labetalol, verapamil, nitroglycerin, loop diuretic. Cardiac conditions: acute myocardial ischemia. Esmolol, labetalol, nitroglycerin. Sympathetic crisis, generally in association with recreational drugs such as cocaine, amphetamine or phencyclidine. Sudden cessation of clonidine or beta-adrenergic antagonist. Pheochromocytoma, rare. Question 5. Which of the following drugs should be avoided in sympathetic crises with hypertensive emergency? Phentolamine, benzodiazepine, labetalol, nicardipine, phenol-dopam. Which of the following drugs should be avoided in sympathetic crises with hypertensive emergency? Phentolamine, benzodiazepine, labetalol, nicardipine, phenol-dopam. Sympathetic crisis. Beta-adrenergic antagonists will result in unopposed alpha-adrenergic stimulation. In cocaine use, beta blockers can increase blood pressure, worsen coronary artery vasoconstriction, decrease survival. Avoid beta blockade, including non-selective agents such as labetalol. Sympathetic crisis recommended drugs: nicardipine, phenol-dopam, verapamil, benzodiazepine. If FeO suspected, use phentolamine. Aortic dissection treatment is paramount. 75% of patients with ascending aortic dissection die in 2 weeks of the acute episode without successful therapy. 5-year survival is 75% with successful intervention. Khan et al., Chest 2002, 122-311. Kauchukos New Angle J. Med 1997, 336-1876. Aortic dissection vasodilator alone causes reflex tachycardia. Increases cardiac ejection velocity. Increases aortic shear forces. Extends the dissection. Aortic dissection standard therapy: nitroprusside can be used as well. Beta-adrenergic blocker plus vasodilator. Esmolol plus nicardipine or phenol-dopam. Nitroprusside can be used as well. Acute post-operative hypertension. Frequent in post-operative state, 20 to 75%. Hyperresponsiveness to surgical trauma. Increased stress hormones. Activation of Ra. Also hypothermia, hypoxia, carbon dioxide retention, bladder distension. Acute post-operative hypertension. Prevention. Safe to give antihypertensives pre-op. Hold diuretics. Treatment: BP thresholds vary. Control pain and anxiety. While NPO, use nicardipine, esmolol or labetalol. Resume oral medications when possible. What happened to sodium nitroprusside? Monsieur and Friedman. Heart Disease 2002, 4-358. Sodium nitroprusside recommended for all hypertensive emergencies except eclampsia. Merrick and Varone. Chest 2007, 131-1949. Sodium nitroprusside recommended for acute aortic dissection, acute pulmonary edema with systolic dysfunction, Riding the pride disadvantages of sodium nitroprusside. Decrease cerebral blood flow and increases intracranial pressure. Can reduce regional blood flow in coronary artery disease. Risk of cyanide toxicity. Use when other agents not effective. Monitor thiocyanate levels. Avoid in renal or hepatic dysfunction. Have we made progress? First described by Vollard and Farr. Die Breitschneier-Krankheit, Klinik Pathologieatlas. Berlin, Germany, Springer 1914-247. Keith, Wagner, Barker M. J. MedSci, 1939-197-332. Mean survival of patients with HTN and grade 4 retinopathy was 10.5 Mo with none living beyond 5 years. We have made progress development of antihypertensive drugs. Increased diagnosis of hypertension. Increased ICU settings. Survival of patients with hypertensive urgency and emergency is 18 years compared to 21 years in those with uncomplicated hypertension. Thank you. Questions? Messerly and Engel J. Med 1995 /33210038